Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 31st, 2023. We do have a CME activity code today, 489214. This conference is being recorded and will be posted by Dr. Baxi on our YouTube channel shortly. Please subscribe to our YouTube channel, and if anybody in the audience is not on our email list, just send us a message and we'll get you on very shortly thereafter. We have nothing to disclose as usual, and also we maintain patient privacy by de-identifying a lot of the information that might be relevant to their identity, and etc. I have a short announcement to make. Dr. Rubin had left the conference because he had conflicting responsibilities, and he very politely asked if he could rejoin. And I told him that we would have to vote on this because not everybody gets automatically to reject us and get reaccepted. So I'd like to just tell him that the five of us voted. It was 3-2. But it was 3-2 in your favor, Mario. So we welcome you back. I won't tell you who the two that voted no, but I'll just tell you that I'm happy to have you back, and you're a vital part of this conference. And even though it was only 1 week, we missed you terribly. So welcome back. We're so glad to have you. We have a great case today. It'll be a fun differential diagnosis. I'd like to welcome our applicants. It is interview time. We have some applicants today. I promise you won't be called on for any discussion or reading the biopsy. You're not on the wheel, which you will see later. So let's go ahead with the case. This is Dr. Baxi's case 2 weeks in a row. He's a superstar. Pravir?
I will get started. So we have a patient who is a 40-year-old woman who we saw in the hospital. Her history was significant for cervical cancer that unfortunately was diagnosed about 2 years ago. And I'll go over the oncology history in a different slide, but she presented to the hospital because of unrelated issues with abdominal pain. This abdominal pain had been going on for about 2 to 4 days, she said. She did have nausea, but no emesis. As a result of this, she was not eating well, nor drinking a lot of fluids. She denied any fevers, chills, and she had no urinary complaints. It was just this abdominal pain. On admission, her creatinine was 0.8 milligrams per deciliter, and going back, this was her baseline. She was afebrile. She was normotensive. She did get CT imaging with IV contrast in the emergency room, given her abdominal pain, and that showed subtle bowel wall thickening of the proximal duodenum or duodenum, however you want to pronounce it, but no other acute findings. ID was consulted given she had cancer on chemotherapy, which we'll get to, and she's immunosuppressed, but there was no indication for antibiotics per the infectious disease team. Interestingly enough, her abdominal pain did get better after a day. She got some fluids, but she developed constipation, and this constipation was so severe that she was requiring multiple different medications, including phosphate enemas, just to get her to go to the bathroom. On day 3 of admission is when our service comes on board, and our service was consulted because all of a sudden she had declining urine output, and her creatinine had gone from 0.8, which it was the first 2 days of her admission, to 1.9. So this is just a graph kind of showing you that kind of acute rise, and the creatinine just kept on going up. So it was 1.9, and it continued to rise to the point where it was all the way up to about 11 to 12. So further information on this case, her abdominal pain had pretty much resolved. She was not having any nausea, no vomiting. She otherwise was in no complaints. Her medical history, I have a slide on cervical cancer and in her chemotherapy regimen, but she did have a history of left IJ thrombolytis, which was being treated per her primary team, and she was on apixaban or Eliquis. She had a history of childhood asthma. She was on apixaban 5 milligrams daily prior to admission, albuterol, inhaler PRN, and she was taking acetaminophen as needed. No family history of kidney disease that we know of, and she was a non-smoker, no alcohol use, and no other drug use. So as promised, coming back to oncological history, which is important, given it was, that was her major medical history. She was diagnosed with cervical cancer about 2 years ago. She was There was metastatic disease to the retroperitoneum. In terms of what was agents that were used before, she had been on cisplatin about 2 years ago. That was no longer current. She had been on a regimen of carboplatin, Taxol, and Keytruda. I'm not going to try to pronounce it and butcher it, but that is a checkpoint inhibitor. That was about 1 year ago. That was started. She did develop a rash to the Keytruda, and she was seen by allergy and immunology and underwent desensitization and was restarted. Her last dose was 4 months prior to presentation, and that was the end of that course. Her most recent regimen, she was started on this new medication with the brand name Tivdak, which was started about 10 days prior to this admission, and this was her first time, cycle 1, day 1. A little more about this drug, which I had to look up as well. It is an antibody drug conjugate that has also what they call a payload of microtubule disrupting agent. Is something similar to what you may have seen before with Taxol and Taxotere. So it is a monoclonal antibody. It binds to tissue factor and ultimately leads to cell death by disrupting cell division. So that's the major general mechanism of this drug. In terms of side effects, it's a very relatively new drug, as we're seeing a lot in this field. There was very minimal I could find in terms of acute kidney injury related to it. There was one article as part of this agent that said that creatinine can increase in 29% of cases, but unknown mechanism. And from what I could gather, it was not severe or persistent. In terms of her vitals at the time when we saw the patient, she was, again, normotensive, afebrile, BMI 49. And as I had mentioned, really nothing to stress on exam. She had no lower extremity edema. She had no rashes. But with her creatinine going up, as I showed you in the graph before, she had become anuric at the time when we saw her. And so her creatinine continued to rise with anuria. Labs that were presented initially 1.9, but her creatinine did go up to the 10-11 range. Her potassium was 4.0. Her albumin was 3.2 with a total protein of 5.5. Her LFTs were normal. MAG was 1.8, FOS was 3.9, her uric acid was 11.4. Her CBC, she had no significant leukocytosis. She had a normal diff. She was mildly anemic at 9.0. Platelets were normal at 430. We did have recent iron stores with iron stat of 50% and ferritin of 800. Her MCV was 80. Her LDH was 500 and her haptoglobin was 250, which is normal. LDH was mildly elevated. ANA is negative. ANCA was negative. These are the results that we had prior to what we had asked for. Rheumatoid factor was less than 15, which is normal. Complements are normal. Microbiology studies were negative. We were unable to collect a urine as she had become anuric, and she was unfortunately had to be started on dialysis with worsening azotemia. We did get she had CT imaging on admission with contrast, as I had mentioned, but we repeated a renal ultrasound that showed, again, no hydronephrosis and normal sized kidneys. And that is the presentation of
So we have a poll. I want to poll. Do people say duodenum or duodenum? But I think I didn't have time to insert that one. So this is our first poll, number 1. What do you think this patient has? Contrast associated nephropathy. Remember, did get a CT scan from her abdominal pain. Do you think it's a TMA? You think it's anticoagulant associated nephropathy, otherwise known as warfarin nephropathy? She was on a NOAC. Acute phosphate nephropathy. She did have some phosphate enemas, and or tumor lysis associated AKI. We'll give you a little time. Everybody can vote. We don't know who you are. You can
pretty good so far.
Vote safely. Yeah, we got a really nice group today. 76. Nice. Javier, you seem to be the big draw lately.
I guess. For now, maybe then I'll drop off because they'll be tired of me here talking. All right, we'll end it there.
So we have the top is a TMA with at 40%. Oh, it's really well spread out. Acute phosphate nephropathy, 33%. We've got contrast associated nephropathy, anticoagulant associated nephropathy, and tumor lysis associated AKI, each having close to about 10%. Dr. Gashti, are you you're on service? You able were you able to listen and give us a differential diagnosis, or do you want me to hand it off?
I'm here.
Okay, great.
So it's kind of interesting. There's a lot going on, but I think at the end of the day, I feel like she came into the hospital with a normal serum creatinine, with abdominal pain, and then while she was here, her creatinine started to go up. So I think my differential kind of is a little skewed because she got contrast, and I think that that's probably the most likely reason her creatinine took off, because creatinine of 0.9 or 1 on admission, and then 2-3 days later the creatinine starts to go up, and she had gotten the dose of contrast. Her cisplatinum, carboplatinum, Keytruda, all that stuff was from a long time ago, over a year ago. Her new chemo Tidvac was a recent start. And I don't know, from a timing standpoint, I feel like if there was going to be a renal adverse event from that chemotherapy, maybe we would have seen that prior to her coming in. So she would have her first creatinine upon admission to the ER, presentation to the ER, that would be elevated. Tumor lysis is always possible, but the only lab here that fits the criteria for tumor lysis was her uric acid level. Her phos was normal, her potassium was normal, her calcium was okay. And again, she came in with a normal renal function. So I think that all of these things point towards an inpatient AKI, which is usually something we do to patients. So it's either we dropped her blood pressure too much from some medication, or we gave her contrast. So I'm going to stick with ATN from contrast-associated nephropathy. But just to kind of put some other things on the differential, there's definitely possibilities of obstruction, as Dr. Reen mentioned. Even though her kidneys are not dilated and she does not have hydronephrosis, there is non-obstructive hydronephrosis in cases of retroperitoneal involvement with tumor. If there's encasement of the ureters, you could get obstructive physiology without actually seeing imaging versions of hydronephrosis. So I'm gonna go with the contrast nephropathy.
So contrast nephropathy is not dead; it's still an entity, huh?
It's on the list.
Well, that doesn't mean everyone believes it.
Yeah.
I mean, you're quite aware.
I
of
mean,
the
it's anecdotally, I see enough of it that I have to believe it.
I'm being sarcastic, but there's been a big kind of change in when we consider it and the like. And we did use the word terminology contrast associated versus contrast induced, which is a subtle difference, but contrast associated doesn't always mean that it's totally caused by the contrast.
Yeah, and I mean, not having a UA also doesn't. It kind of doesn't help, because we're not able to parse out whether this is the patient has hematuria, proteinuria. Usually that's the first thing I look at to see if I'm dealing with a bland UA and hemodynamic AKI versus sort of a more of an active UA and a possible proliferative GN. So that piece of information missing broadens the differential to kind of everything under the moon. But I think, to me, every time a patient comes in and then the creatinine goes up 3-4 days later, it's something that's happened in the hospital.
And I think that's good experience, and I think that's very wise. Anuric contrast, I think, would be unusual, and the timing seems a little, 3 days out or something. But that's certainly possible. But I think your point about what did we do is really not.
And her pressure is soft. So I mean, I see a lot of comments about contrast not causing this degree of AKI, but in the right setting, somebody who may be a little volume down, maybe a little soft blood pressure, 100/60, in that setting, nausea, vomiting, abdominal pain, maybe she was a little pre-renal, even though her creatinine hasn't bumped. And in that setting, contrast could give you this kind of picture.
Mm-hmm. Great. Yes, go ahead.
For the trainees in the audience, would you please go over the differential diagnosis of anuric acute kidney injury?
So papillary necrosis, if you have, that's kind of the big one.
You mean cortical necrosis?
Renal cortical necrosis.
I'm sorry, renal cortical necrosis. If she had obstruction. You know, if she had like a bad, like acute GN, that's pretty much, you know, those are your anuric ones.
Bilateral renal artery occlusion.
There you
Yeah,
go.
that's right. That we might see with catastrophic antiphospholipid antibody syndrome or some sort of significantly vascular, like a really bad TMA, infarct.
Yeah, an ATN isn't supposed to give you anuria, but I always say it's more common to find an uncommon presentation of a common disease than a less common disease. But
Wow, could you say that again? You said that you said, well, I don't know how many times you said common or uncommon.
it's more likely to see an uncommon presentation of a common disease
there we go.
than an uncommon disease.
I'm sure you said it right. I just needed a little repeat. Thank you.
You're just mad at me.
No.
Hoping I'd screw up.
No, never.
Man, this conference is getting tough. It's between pronunciation and, you know.
No, I just didn't follow. He's just way over my head as usual.
I thought this was a carryover from the steroid sparing conversation. Is that too soon?
Exactly. That's
We're not going there.
Dr. Boxey,
Why
you
does she have
mentioned- Dr. Boxey,
Yep.
you mentioned that, excuse me, that non-obstructive acute kidney failure with anuria can be seen when retroperitoneal involvement bilaterally occurs. I must say that it can also occur in acute total urinary tract obstruction at the ureteral level. I have seen patients who develop anuric AKI with no retroperitoneal involvement, but with ureteral involvement bilaterally at the level of the bladder, in which there was no hydronephrosis, at least when studied during the acute phase. It may have occurred later, but not during the acute anuric phase. So I think you don't need to have widespread retroperitoneal metastasis, although this patient did have that. But you are correct that encasement of the ureters will prevent hydronephrosis in chronic obstruction. But in acute obstruction, I must say, I don't think it's absolutely required.
So is that, Dick, is that usually associated with severe abdominal discomfort? Because I thought with acute obstruction, you know, from various causes, you'll get a fair amount of discomfort.
Yes, and I wonder what the abdominal discomfort was, although she had that preceding the episode of acute kidney injury, whatever it is. Yes, you do see more like a colic, but
Yeah,
that's a good point. I can't recall whether pain has been a uniform finding with acute anuric ureteral obstruction.
I have seen a case of prolapse uterus giving anuric kidney disease, and she actually was a dialysis. So when I came on service, she was complaining of moderate abdominal pain, not severe. And actually, we put the Foley catheter and a creatinine boost, got her operated, and she was off dialysis. The other thing which I think is ferritin is 800, LDH is slightly high. I know she got immune checkpoint inhibitor about a year ago, but TMA is a possibility in this case. The only thing I cannot explain is anuria. That's what I was. I will keep in mind that too.
I'd like to point out that the last dose of the checkpoint inhibitor was just 4 months ago. So
4 months, okay.
yeah.
Roger?
Yeah. I just want to make one point, Mario, and that is, you know, I know this is biopsy conference, but I can't stress enough what the last 5 minutes have been talking about is don't miss obstruction, don't miss obstruction, don't miss obstruction. And we know we rely on the ultrasound, and boy, that's a slippery slope sometimes in a case like this. So I'm glad that we had that discussion. So Mario, yes.
Yeah, and along those lines, again, for the trainees, additional causes to consider of a false negative ultrasound in the setting of obstructive uropathy are volume depletion, chronic tubulointerstitial disease, and retroperitoneal fibrosis. So those are the other considerations that we should keep in mind.
Exactly. So, anybody have any strong feelings about other than Dr. Gashti's contrast? I think Dr. Reen, what is your number one here?
Mine is actually acute phosphate nephropathy or non-dilated hydronephrosis. I would think that. Contrast-induced nephropathy. I am not convinced IV contrast, even in the setting of hypotension, volume depletion causes that kind of rise of creatinine. She could have ATN, again, very unusual to have total anuria. So my first diagnosis would be non-dilated hydronephrosis, and I'm hinging towards acute phosphate nephropathy.
So acute phosphate nephropathy was a big deal about 10 years ago, or maybe 15 years ago now, and it was pretty much a bowel prep thing. This was phosphate enema. Now, it had been described with phosphate enemas, but I think it was mostly described with smaller, older people whose GFR was abnormal but underestimated because they were smaller and older, and they got a bowel prep with these large burden of pills. And of course, the idea is that it's a cathartic and you wouldn't absorb it, and it would cause to clear out your gut. But obviously, some got absorbed, and these patients, would 3 days later, they'd present with renal failure, and people wouldn't even. I remember I had a case years ago. It wasn't even on the radar until we said, "Well, what's been going on?" Well, I had a colonoscopy a few days ago, and we said, "Oh, well, what about this?" And sure enough, I think it's been the bowel prep has been pretty much replaced. I don't think they use those doses, and I think it has been reported with enemas, but not as much as the old bowel prep. I haven't seen a case in years, but I like the fact that it's on the differential diagnosis here. Regardless,
has been reported with enemas. Actually, the report came from Dr. Juan Olivero at Houston Methodist, and as you said, almost 15 years ago. I have also posted an outstanding review by Dr. Elliott here and his colleagues at Harvard on oral phosphate and acute renal failure, which is worth reading.
and I kind of like it in a way because it's an acute tubular. You would not be it's not an obstruction per se; it's a tubular obstruction, and so you wouldn't see any hydro or anything, and it would be I could imagine. I don't remember if these patients were anuric or not, but you could imagine it possibly doing that because it's
Well, don't they get calcium phosphate obstructing in the tubules?
It's calcium phosphate.
Yeah.
Yeah, it's a tubular. It's acute uric acid nephropathy, but it's acute calcium phosphate nephropathy. Yes, Dick.
It'd be interesting if you polled the participants today, not necessarily knowing what happened to the creatinine over the next 5 or 10 days, but at the time it was discovered that she was anuric, how many would have called the urologist to do a cystoscopy with an attempt to catheterize the ureter?
And I think that's an important point, and we will get back to that, I promise. Because
Okay.
I think that's a very relevant question. And we thought about putting a poll in there, but we didn't want to bias the audience or give anything away. And I'm not giving anything away, trust me. But Dr. Baxi will address that because he's kept his mouth shut, but he's probably the most keen on this diagnosis of anybody in the audience. So
Since he published on it.
yeah. So
I would
where are
say
we?
whenever you have this rapid of a rise of creatinine, obviously in the hospital, we're always seeing a hospital acquired, just like Dr. Gashti was talking about, but not necessarily an anuria, but vancomycin is one of those ones where your creatinine may more than doubled, even though your, in that you wouldn't see complete anuria, but you always want to think about that in somebody in the hospital. Now, this patient in the history didn't get vanc, but anytime I see that really more than doubling the creatinine, I think about vanc. And I think Juan Carlos Velez did a nice study and reported on that, where he compared the elevation in creatinine compared to cystatin C elevation. And obviously there's issues with cystatin C, but what he showed was that the creatinine elevation was much more out of proportion compared to the cystatin C elevation, showing that it may not be true renal failure that's causing the more than doubling of the creatinine in the setting of vanc.
I thought that study was with vancomycin and tazocin. And that because that was the proof of 2015-16, that was a big deal. And actually, it was the tazocin part which showed the pseudo rise of creatinine because cystatin C was normal. Am I saying the same paper you're talking about?
I thought it was also the vancomycin.
I'll take a look,
Yeah,
Dr.
both
Reen.
of
I'll see if I can post it for us.
Yeah, it's still a good point. I like the thought. I think the money here has to be in the anuria because this is she comes in with not much and then bingo, man, she stops peeing. Not everybody has two kidneys. You can always some people have one kidney and then they infarct that kidney. But I think if that were the case, her LDH would have been higher. Well, let's go on and let's see what the biopsy shows. I'm going to spin the wheel. We'll see who reads the biopsy. Looks like it's Saba. Saba is one of our second-year fellows.
All right, Saba, I'm going to give you control here. Give me a second. Go ahead and test your audio.
Okay, can you hear me?
Yep. All right, click on the screen.
Oh man, I haven't done this in a
Yep.
while.
You got it. It'll come back. It's muscle memory.
Yeah.
Like riding a bike.
All right, so here we have a trichrome stain with one core. I see several glomeruli here, and then I'm looking for the blue staining for any fibrosis, which I don't see very much of, so maybe like 5% or so of fibrosis.
Yeah, it looks like a good healthy core of tissue. Yep, very minimal.
Okay, so here we have an H&E stain. I have one glomerulus here in the middle. It looks maybe like a little bit lobular around here, but it looks intact, which is good. There might be a little bit of mesangial expansion here, maybe a little bit of hypercellularity.
That's around the hilum. Do you see the attachment down there at 6 o'clock? So that's a normal hilar area.
Okay. And then looking at the capillary loops, they all look closed to me.
No, they're widely
I mean open, sorry. By closed, I mean open.
Okay.
And then looking at the tubules kind of surrounding, it looks like there's a lot of, I don't really see much brush border along any of these tubules.
Yeah, so we'll see that you need the PAS stain to see the brush border. This
Okay.
is H&E. But that one down at the very bottom where you were, yeah, that one, epithelium looks a little disrupted. So I'm sure we'll see some ATN on other slides.
Yeah, so right here.
Yes, this glom, yeah, that glom looked pretty normal.
Yeah. This glom does not look as normal. So another H&E stain. It looks like there's some fibrosis or thrombi here.
Yeah, these are intracapillary thrombi.
Thrombi, yeah. Again, maybe a little bit of hypercellularity kind of around here. But otherwise, the glomerulus itself looks intact. And then again, kind of like you mentioned with the epithelium around here, it looks like it's maybe sloughing off. I'm not sure, are these also thrombi?
So those where you are right now, those are hyaline casts in those tubules, and then in the right, yeah, that one there looks like a red cell cast because I could see red cells, and then there's some ATN in the tubule right at 3 o'clock. Yeah.
Okay. Again, another H&E stain. This looks like the glomerulus here. Hilum is right here.
Yeah, so right there, yeah, you're on it. intracapillary thrombus.
Another thrombus here, okay.
Yeah.
And then some sloughing here at the tubule.
In fact, yep. On the next slide, that's the same glom now on PAS stains. You could see that that lumen is obstructed by the private thrombus. Yeah, right there. Yeah, probably right at the hilum as that arterial comes in.
Uh-huh.
Nothing beats the arrow sign.
Positive arrows.
Positive arrow sign.
If you go back,
Could you go back, David? Is that like a double contour right there, or where the arrows, or are you just showing?
No, I'm pointing out the intracapillary thrombus in case it was overlooked.
But I think Pravir brings up a good point. Doesn't that kind of look like a double contour?
Yeah,
This might be a little more chronic.
It kind of vaguely does. Yeah.
Okay.
Yeah. And then you can see the JG apparatus nicely, the macula densa. In that distal tubule.
Here we have the Jones stain or silver stain. So everything looks intact here. The capillary loops look open. I don't really see any spikes or holes along the capillary wall. So this looks pretty good to me.
Yep.
So we have another H&E. This don't see any glomeruli, but looks like we're looking at the tubules, and this looks like a lot of debris almost.
Yeah, good intratubular necrosis. The epithelium is sloughed off and necrotic, filling the tubules.
So a lot of sloughing here.
Yeah. And then we'll have the same area on the PAS stain. Yeah.
Okay. So you can see that. And this is where you kind of see the loss of the brush border. That's sloughing.
Right. Yeah, especially in the tubules with that necrotic debris. Yeah, there's no brush borders.
Acute phosphate nephropathy, David, was on the differential. I mean, what you would need, I know you need a special stain, but would there be anything else you'd be looking for? I mean, you'd be seeing some deposition. I mean, that looks like just ATN, but could you just describe what else we would see?
No, in fact, I did a von Costa stain and was negative.
Okay.
Okay, so immunofluorescence for IgG, it's negative. Here we have an EM slide. Just to orient myself, this space out here is the urinary space, and then we have the blood space in here. The basement membrane from here, I can't tell if it's thickened or not, but it looks okay to me. There's podocytes going all the way around, and I don't see really much effacement at all. And then I also don't really see any electron dense deposits either.
Yeah, good Saba. Yep. Podocytes that preserved.
Yeah. So a little bit higher power, again, urinary space, blood space. Podocytes here look pretty good all the way along. I don't see any effacement. And again, I don't really see any deposits on this slide.
David, do you see any endothelial abnormalities on that loop?
No, I know. The endothelium looks pretty right on the basement membrane to me here.
Yeah, no, I agree. I mean, in the setting of a TMA, it's interesting that is absolutely normal.
Yeah, the TMA was only focal 3 out of 27 glomeruli. So the EM we see here on the sample was probably normal, is normal.
David, you'd expect, besides that, you might expect what, the wrinkling and ischemic changes?
If it's a bloodless glomerulus, or otherwise you might see some endothelial swelling.
Okay.
Plus, you would expect to see some ischemic glomeruli, I would think, along the way too, right?
Right, yeah. Yeah, I didn't see any ischemic glomeruli. I would have shown those.
Okay, so diagnosis is pretty severe ATN with TMA.
Good.
Yep.
So we're going to take this to, I believe we got a poll. Yeah, so we have a poll now, and we're going to poll the audience. What would you do now with what you have? Would you offer this patient plasmapheresis, offer this patient eculizumab? Would you get complement studies, or will you just monitor this patient alone? And then we'll kind of open it up for discussion. But I didn't want to I didn't want to discuss it until we polled people. So.
Pretty good. Wait a few more seconds here. Quite interesting. Nice.
Nice response.
We'll stop it right there. And people
Okay,
will
we've
see
got a good
results.
mixture and no mandate. The only one that didn't do well is eculizumab, but it's pretty equal between plasmapheresis complement studies and monitor alone. And I'm going to hand it back to the faculty and see what they would do. Steve Corbett, what would you do at this point?
Sorry, I'm trying to unmute. Personally, I think I might get complement studies. I mean, if this is malignancy-associated thrombotic microangiopathy, plasmapheresis isn't going to be of much value. And I think the one thing that might be treatable is a complement-mediated abnormality. So I would, do an evaluation for, Adams 13 antiphospholipid antibodies. I think I would look at that first. I mean, the assumption, I guess, would be that this is a tumor-associated thrombotic microangiopathy. She didn't get any, any of the medications, gemcitabine or any of the medications associated with the TMA. But the one thing that if she had it, might respond to eculizumab is one of these complement-mediated abnormalities. So I think that's what I would do, and then go from there.
Well, I also don't think it's mutually exclusive. I think that a lot of these, we're seeing a lot of TMAs are underlying complement disorders, and then the second hit happens to be something else.
That's true too.
And I don't know about, I mean, chemo. Yeah, I mean, you mentioned gemcitabine, but
yeah, mitomycin C, gemcitabine. She didn't get any of that.
No, but I mean, a lot of the new chemotherapy agents. That's one of the major factors of their renal toxicity.
Yeah, mostly it's tyrosine kinase inhibitors, but
and then VEGF.
Yeah, VEGF for sure.
And a VEGF, but she didn't get any of that. And I was glad that Pravir gave us a little rundown on that. I was like frantically looking it up in Hippocrates to see if there was anything associated with it. I couldn't find it because the first thought is always that, what's the new agent she got?
I think they've been reported with checkpoint inhibitors, but I know that obviously it's interstitial nephritis is the most common lesion there. But I also don't know, the interstitial nephritis can be delayed. Like in this case, it was 4 months. That would be classic. But I don't know about a TMA that would be delayed. That would seem a little strange.
I mean, it is interesting that this all precipitously happened in the hospital. I get back to Casey's, description of the sequence of events. And it is kind of interesting. It's like a cirrhotic comes in the hospital and it's all of a sudden something we do, and then they have a hepatorenal syndrome. I'm still wondering, whether or not the intravenous contrast that she got might have tripped something off. I mean, we know for sure that intravenous contrast can trip things off, like, cast nephropathy, just like furosemide can. I don't know if it could. I was wondering whether or not it might trip off something like tumor lysis and cause intrarenal obstruction with uric acid, but clearly she doesn't have that. I still kind of wonder what tripped this whole thing off, because you would think thrombotic microangiopathy would be occurring over time, not just occurring the minute she hit the hospital and then have acute renal failure. So I don't know, David, you showed a fair amount of ATN, right?
Yeah, it was patchy and diffuse.
So, I know that the thrombi don't always necessarily correlate, but you wonder whether there might be two things going on here, and we just happened to trip we kind of stumbled across the thrombotic microangiopathy, but what might have caused it was this ATN possibly from contrast associated.
I think, what I would fairly confidently say is that even though TMA can cause this degree of renal failure and anuria and cortical necrosis. This degree of TMA that we saw in this biopsy is not responsible for this degree of renal failure. I think that you're right. I think we're picking up two things, and we'll have to sort it out. Dr. Reen, you had brought up the checkpoint inhibitor related TMA. Do you have anything else to say about that, timing or anything?
Yeah. Well, I would have thought I would have seen more endothelial swelling in that situation. So I think more likely it is malignancy associated TMA. And as I made the point earlier, there was some rise of LDH, and it is so renal limited, we may not see other abnormalities such as low heptoglobin and low platelet. So I'm hinging towards more the tumor associated. Acute interstitial nephritis and TMA can both be caused by immune checkpoint inhibitors. Is that a scenario possible? But I think it is mostly tumor related and acute tubular injury because hypotension, whatever the cause. But I wouldn't rule it out. Immune checkpoint inhibitor, both causing interstitial and TMA.
Yeah, you had mentioned endothelial changes. I don't know that there's anything specific about it when you look at a TMA that'll tell you it's a pattern of injury. And I don't know there's any much that you can look at it specifically that would tell you where it came from. I mean, I think a
Roger?
TMA. Yes, Dick, please.
Taxanes have been associated with TMA, and they are anti-endothelial factors. Does this drug that she just got started on have taxane-like properties?
That's what I understand, and that's from what it's a brand new drug, but that's what I gathered. It does have very similar that acts like taxane, just like Taxol and Taxotere, as part of this antibody drug conjugate.
Well, both Taxol and docetaxel has been associated with endothelial injury and TMA, and I suspect that because that was the most recent drug she received, that has to be listed as a possibility. And I would certainly agree with Steve Corbett that plasma exchange really doesn't have any role here at all, I don't think. Whether that TMA due to taxanes has a background of complement factor deficiency, I don't know, but it's something probably worthy of looking at.
I just know that
complement deposits at all in the IF, right?
That's correct. There were none.
Okay.
So Dick, let me take the opposite view. TMA is usually the result of a two-hit phenomenon. There is a background of a mutation or the presence of antibodies directed against certain alternate complement pathway factors. Sending complement studies is a great idea, but it will take at least 2 weeks to get them back if you're lucky. So this lady with a neuric injury cannot wait 2 weeks for us to decide on what to do. Could be the tumor, could be the drug. I don't know. Personally, I think that we cannot tell, as Roger has suggested, what is the reason for the process. Could be a alternate pathway factor mutation or an antibody or both. I don't know. But personally, I would use pheresis and eculizumab and wait for the results to fine tune when they come back.
It's funny because we were when Pravira made and I made up the poll. We have pheresis and eculizumab or just separate, and that's I really like this paradigm of TMA being a lot of these patients have an underlying complement deficiency, and then there's always a second hit, which is I think what you're alluding to. Even with malignant hypertension, there appears to be some of that, and so there may be a role for eculizumab in a lot of these patients. And we do a lot of treatments before we have a diagnosis. I don't think that's a bad idea. We're we've a little bit of time left, so I think let's hand it back to Pravir and tell us what he knows and what his thoughts about the case were.
Yeah, absolutely. So I wanted to first start off giving the additional data. There was some more stuff that we did get back. We already knew that LDH was 500, haptoglobin was 250. That's the first thing, we thought about when we saw the biopsy with the TMA. Now, again, this was renal limited, which would mean that, you don't necessarily have to see any other extrarenal manifestations of this microangiopathy. We did get hematology involved. They suggested a CUM test that was negative. And hematology was able to send out through Mayo the atypical HUS complement panel that looks at several different complements, factor H, and all that came back. It did take a couple weeks, but it was negative. There was no serological evidence that we had that was reported that she had any complement abnormality. So that was useful information. She had abdominal pain. She was immunosuppressed early on. Before the biopsy, we sent off a CMV. We did blood cultures. All that was negative. Now, coming back to Dr. Glassick's point of would you have stented this patient, doing a poll before the kidney biopsy? In fact, that's exactly what we did. I had a high suspicion, and I invited Dr. Shahzada Sim, one of our fellows, graduated 2 years ago. He unfortunately has an appointment, but we had this very interesting case. And the first thing that came up, of course, was this was anuric AKI, something happened in the hospital. When we looked through the chart, yes, we saw the IV contrast. Yes, we saw the phosphate enemas, but something just didn't seem right. This was quite severe, and she had metastatic disease to her retroperitoneal area. The CT did not show any type of hydronephrosis. Renal ultrasound did not show any hydronephrosis. I put this in the chat. We even got imaging of her arteries. A bilateral acute renal occlusion was also on her differential. That was also not revealing. And so we talked to urology, and she was on Eliquis. We had to wait 3 to 5 days, at least 3 days before getting a kidney biopsy. And I was able to convince urology at Rush to stent her. So they did a retrograde pyelogram. They put in bilateral stents. And in fact, if you go back here, give me a second here, that little blip that came down in terms of her creatinine, we were quite excited initially because she made a little bit of urine, even though mostly blood, and then started going up again. So unfortunately, bilateral obstruction, non-dilated obstructive uropathy, even though it's one of my favorites, was not the case. But just a little background on this, and this was mentioned already, which is wonderful, is that you have to have a really high suspicion for this. And it is typically in cases which patients have metastatic disease to their retroperitoneal, but as Dr. Glassick said, there can be cases where there's not. And why don't they get that dilation? There's several thoughts. One is some of these patients have, of course, metastatic cancer. They're hypovolemic. They may not actually develop any backup or see the buildup of hydro. Other times they have these encasing of the ureters, and so again, they cannot develop hydro. And so CT imaging can be negative. And that's really hard to convince someone when you have negative CT imaging, which is our gold standard for hydronephrosis, that go stent this patient. Fortunately, we've seen, this would have been my 4th case. I've seen 3 of these, and this patient is the one we published, and it was quite dramatic. And why is this important? Why do I love this? This is a patient who unfortunately had a very poor prognosis, had metastatic breast cancer. And this was 4 years ago. She developed AKI, just very similar. She became anuric, ended up on dialysis. She also had DVTPE, not uncommon in these metastatic malignant patients. And unfortunately, she was bleeding, anemic, and it was determined she would be too high risk for a kidney biopsy. So this was all thought to be ATN from bisphosphonates, and she ended up on dialysis. It wasn't until her oncologist saw her and referred her over to us as saying, hey, this is unusual. And we had urology stent her, and this was so dramatic. Again, this patient was on dialysis for about 2 months. She gets here, she gets a stent placed, and her creatinine goes from 9 post-HD anuric to normal in the span of 48 hours. Her urine output was 7 liters a day. She had a massive post-obstructive diuresis. And this lady, unfortunately, did pass away. She had a very poor prognosis, but she passed away not on dialysis. And that's why I think this is a very important entity to look out for. And it is rare, but it may be more common than we think.
Just as an aside, I mean, on the biopsy with obstructive uropathy, I mean, there are features that you see. And I don't know that there were any of those here. I would think you see congestion, but for sure things like monocyte chemoattractant protein increases lymphocytes into the interstitium. We saw really nothing in this to make you think there was any kind of obstruction, I would think. I mean, because in this case, you do have a biopsy to look at as well.
Yeah, we do have a biopsy, but we stented her. It did not improve the outcome here. And this is for us. Unfortunately, he could not make it. He did present this as ASN and then subsequently published it a few years later. Acute phosphate nephropathy was also the thought that I had. Of course, she was getting these phosphate enemas. You know, this was just so unusual that she had shut down. And fortunately, the von Costa stain is the stain that you want to look for, and these patients can get it. And for this patient, she would be someone that may be a higher risk for this. A lot of these patients who get this are volume depleted as a second hit. And she was not eating. She was nauseous. She had abdominal pain. Ours was negative, but this is a stain that you can see. And we've kind of talked about this already to some extent. Finally, we talked about TMA from checkpoint inhibitors. Now, the timing we kind of mentioned, you would assume that it would happen a lot sooner, but a lot of the checkpoint inhibitor adverse events happen months to sometimes a year later, including acute interstitial nephritis, especially with those are PD-1 inhibitors. And there is some limited data on TMA with checkpoint inhibitors, and it's not much, but if you look at this table, this is from a recent article last year that had, again, these all case reports of different checkpoint inhibitors that have been used, some in combination, skin cancers, lung cancers. A lot of these happened almost, I mean, this is 6 months after initiation. This is the amount of days that the patient has been on checkpoint inhibitors. Of course, this patient was stopped 4 months ago, but it would not be out of the realm of possibility, I would think, that could this have been somehow related to checkpoint inhibitors? Again, what goes against that? It looked like this was much more acute, not more chronic. Again, I don't know the answer, but this taxane theory with the new medication, that timeline would make more sense because that was within 1 to 2 weeks prior to the biopsy versus 4 months. But nonetheless, that there is TMA associated with checkpoint inhibitors, which I did not know much about. And it can, again, happen much after, just like many of the adverse effects that can happen with these medications. So what happened with our case? So I did stents before the biopsy. The biopsy was done right around here after she had been started on HD. We had held the Eliquis. While the stents initially gave us some really high encouragement, and I was very happy that day. I was excited coming into the weekend. Unfortunately, she did not. She kind of closed down again. So what we did in the meantime, there was concern that because she had checkpoint inhibitors, could have been AIN, unlikely. I didn't want to miss anything. I pulsed her. I pulsed her with steroids while waiting for the biopsy, not taking a chance. We had to start hemodialysis, and she really did not make much urine. She made a little more urine after the stents. She was making maybe 100, 200 cc's, but not much. We got the kidney biopsy. We, as I mentioned, we got heme involved. We did not do plasmapheresis. We stopped the steroids after the biopsy, and she started to make more urine. And sure enough, this patient, after our last hemodialysis session, she recovered. And this is almost 3 weeks after her last session. Although she's not gone back down to normal, her creatinine is just around 1.52 as of the last check. So the question remains, was this from the chemotherapy? I definitely think that the majority of her acute injury and the creatinine rise was from the ATN. Again, given that there was only, I think David said 3 gloms with some acute TMA, it was focal, but she had diffuse ATN. It doesn't solve what caused the ATN. Could have been the contrast, could have been volume contraction plus the contrast, or it could have been just from the new chemotherapy, which can cause ATN. Any of these can. Good for the patient she came off. Now, I think the question then becomes is, what do you do for it? Can she have this chemotherapy again? I don't think so. How about checkpoint inhibitor rechallenge? I know in acute interstitial nephritis, we often empirically treat these patients with steroids and they get rechallenged with steroids because these checkpoint inhibitors have been proven to be quite useful in when patients have no other options left. But, I think this is still a fresh case. Time will tell. Right now, she's off all her chemotherapy. She's off dialysis. Her creatinine is stable. I think the important points I have from this is that, there is renal limited TMAs that can be associated with checkpoint inhibitors, and that should be something on our radar as these being used more. Non-dilated obstructive uropathy is something I think about all the time, even though it's very rare, and we should think about, especially in certain patients when all of a sudden became anuric and they do have retroperitoneal involvement. And the question I don't know is what to do now. If this was checkpoint inhibitor induced, do we re-challenge her? Is there other chemotherapy options that she even has? And that's, I guess, more of an open-ended question, and time will tell, but that's kind of where we are right now.
I like the idea that this was delayed checkpoint inhibitor. I like that. And I think that that doesn't mean you can't give it, but I would not assume that it wasn't. And I think you might want to, you know, as they do with after acute interstitial nephritis, you know, if they think it's an important treatment, cut back on the dose.
I remember a few case reports with gemcitabine, TMA, and using eculizumab, and they were able to use that drug. I don't know if you have to use it, probably that may be an option, trying eculizumab plus add the chemotherapy.
Did those patients, I'm sorry, Dr. Reen, did those patients have complement deficiencies? Is that why the...
I don't recall, I have to read the paper, but I do know that that has been tried.
Yeah, I think I vaguely remember something about that, that it's, you know, you can use it with eculizumab, but I don't know with the normal complement studies if that even would, if that would be so much the case here.
Problem with that is also that sometimes the mutations aren't even detected. I mean, a normal complement mutation in a genetics screen with these may still not be, you know, there may be something new. And then there's one, coming back to eculizumab, there's one, this is the most recent case that this where this article is from, they used eculizumab and it did not work. Again, case of one, but you know, they did try doing eculizumab in this patient.
And that's a recovery and not so much prophylactic. I'm sorry, Steve.
No, that's what I was going to say. From a practical standpoint, though, who has the final word at Rush on who gets eculizumab? I mean, my impression was hematology makes the final decision, and I don't know what their criteria are.
Well, my experience is that they'll pull the eculizumab trigger a lot easier than I would pull the eculizumab trigger.
It's interesting because it may depend upon who the attending is. Because I know there was we've had patients in the hospital in the recent months, and I think it was one of Previr's where there was a whole issue of there was some concern that there was a TMA that might be eculizumab responsive, and the heme refused to give it.
Roger, the other point to remember, which has been brought up by this lovely lady from Washington University, she's a transplant nephrologist, I'm blocking on her name, is that patients can have functional abnormalities in the alternate complement pathway proteins, which unless you test for, you're gonna miss it. So the report of Mayo indicates, that's it, Dr. Baxi just put her name, I mean, what I was gonna say is that the report by Mayo does not rule out a functional complement abnormality.
Can you explain that to me, the functional complement? What does that mean?
Well, you look at the function of these proteins. I mean, Dr. Java has written a paper about it, which I can dig and send it around later on. But basically, there is a way to test on how these different proteins of the alternate complement pathway function in the milieu, and some of them don't function properly, even though the quantity is fine, even though there are no antibodies against those factors. That appears to be another issue.
Is this like protein CNS activity versus the amount? In other words, looking at the function of,
that would be a good analogy.
Yeah.
I have a note from Dr. Java. She suggested that genetic, antigenic levels, and if needed, biomarkers in this type of situation. I don't understand all these things, but I'm going to ask her again, what does she mean by it? And she's talking about functional complement too. So what Dr. Rubin is saying, doing AHU's panel actually doesn't rule out underlying complement mediated TMA.
So Pravir, what did this lady, I know you've said it, I'm just trying to remember, what does she finally bottom out at as far as what was her final creatinine? Where did she level off?
She's around 2. And that's at least 3 weeks after her last dialysis.
And that could
she's
either
no
be
longer-
from residual damage from that awful ATN, anuric ATN, or it could be some of that TMA as well. Dick, you would want to make a point?
Well, there seems to be a school of thought emerging that her anuria was due to ATN, and that this thrombotic macroangiopathy is kind of an incidental finding. I must say, I would take the opposite view that we're just seeing the tip of the iceberg with the thrombi in the glomerular capillaries, and the evaluation of the functional attributes of the endothelium by morphology is notoriously insensitive. Transmission electron microscopy really doesn't tell you what's happening with the fenestrated endothelium, the glycocalyx around it, the ability of water to move across the endothelium. And we know that diffuse endothelial damage can produce oliguric acute renal failure. Certainly that's true in pregnancy-related situations. And my impression is that I would have loved to have seen more detailed studies of the endothelium to say whether or not the oliguric or anuric acute renal failure is due to tubular necrosis. Perhaps that's old-fashioned, because we often attribute the renal failure to the necrosis of the tubules, but there's always a lot of other things going on. I'm more inclined to think that this was chemotherapy-induced acute thrombotic macroangiopathy with acute renal failure, and the ATN is incidental.
Wow. I'd be willing to bet you on that, but we'll never sort that one out. I do like the controversy, though. I mean, I was certainly from the 3 of 27 glomeruli, but that, you like I said, it's the tip of the iceberg, so it's really hard to say.
But we didn't
that,
do anything to address the TMA, and the patient's renal failure got better. So how does that add up?
Well, you remove the
Patient didn't get any more chemotherapy, right?
Right.
No,
There was
none,
more
no.
insult. She had spontaneous recovery of an acute episode of TMA induced by a therapeutic agent. And this is all spontaneous recovery.
I mean, the sad truth is, this lady still has this cancer, right? And so the question is cervical CA, I assume I don't recall, but it's metastatic, I assume?
Yeah,
retroperitoneal,
metastatic
remember?
to primary retroperitoneal.
Yeah, sorry.
Yeah, metastatic.
Yeah, I mean, so really at the end of the day, it's kind of that becomes the bigger issue for her. I
Yeah.
mean, the kidney is no
Right.
small thing, but dealing with this cancer is going to be a bigger one, and then trying to decide what chemo to give her next is going to be, I think, a huge thing.
Right.
But the cancer was not playing a role in the TMA here because nothing was done to it. I mean, it's basically, as Dr. Glasser points out, the drug was removed.
Fair enough. It's just a question now is what drug can they use next?
Right.
They're going to have to use something. And it's you either bite the bullet and take a chance, or you do nothing and she dies of metastatic cancer.
And as always the case, we talk to our oncologists and we say, well, is this these drugs really making a difference? A lot of times in the past, we think, they're not doing that much. They might buy a little time, but these newer agents are really quite remarkable. And I think it's a much more relevant question, because, certainly the checkpoint inhibitors, you don't throw the baby out with the bathwater, because they're really amazing. And probably some of these other new drugs are coming along every week that we don't really understand. I think it's it's too easy to just say they can't give it. Because of some side effect that we may or may not understand.
Yeah, I think that in this situation, that becomes a secondary issue. You give them the options as to what the side effects are, and then you go with what you think is going to be best.
Yeah. Any more comments? Great case, everybody. Really great discussion. I think that we made the right decision in bringing Dr. Rubin back into the faculty. So welcome back, Mario. You've proven yourself worthy of being here.
Thank you very
Thanks
much.
a lot.
Okay, so we'll wrap this up. Activity code. Did we double check that, Pravir?
Yeah, apparently it's not been working. I just emailed CME and we will, if you still need it, just email me directly and I will, once I get the updated what's going on, I will let everyone know.
Yeah, we've had some issues getting a proper code, so it's good for a few days once you get it. So we'll try to get it. Appreciate everybody's contributions, and we should be back next week.